Good evening, everyone. My name is Sherry Moore, and I'm the Vice President of Risk Management at PLICO. And I want to welcome you all this evening into this unique opportunity and experience of a CME via Zoom. And I want to thank you also for your time for this evening. I hope that soon we will be able to be back together in real person and talking. And I encourage you all to participate tonight, to be engaged, and to really add questions, do whatever. If there's something that you have a question about, add questions. We're going to have polls throughout. I do want you to know if you're logged in and you cannot hear, you can send a chat to MD-Zoom support, and that will hopefully help you. Obviously, if you can't hear, maybe that won't help, but if you start having problems, or you can call 405-408-6205 if you start having any issues. The chat function is probably your best bet. Tonight's program, for those of you who stay logged in and engaged, is worth 2 hours of Category 1A CME. In addition, for our MDs and PAs that are joining us, this does meet the requirement for your opioid education for your licensure. So when you have that question on your licensure renewal, you can say that you have gone. That is if you go in, complete the evaluation, and get your certificate. So please do that. I will be sending that out tomorrow, the link for your evaluation for you to get your CME and your certificate. In addition, you'll be receiving a 4% credit on your July renewal if you are with Solutions Practice Management. If you're on your own policy, then that will apply to your next renewal. We have opportunities for you to get additional percentage of credit. So if you're interested in that, please call us at the office, 405-815-4803, and we can help you with that. In addition, as I said, we're going to have polls this evening. And so the first thing, we'll have them throughout the night. And so the first thing I would like for you to do tonight is to choose your title. And all you have to do is just go click on the radio button, and it will, we'll see where we are. All right. I'll give you just a couple of more seconds to click on. Okay. All right. So as I can see here, about 57% of you are going to be really happy tonight because you're getting your opioid education requirement. And if you have questions about where you can, our osteopathic physicians and our APRNs, just again, give us a call. We'll do our best to help you find somewhere that you can get that credit. So we're going to get started tonight with our program. It is called Missteps in Medication Management. And our objectives this evening are, first of all, to recognize the impact of medication errors in the professional liability claims, to discuss examples of medication-related events leading to patient harm. It's not big, it's still little. And identify strategies to address medication errors, and discuss the legal requirements for opioid prescribing in Oklahoma. What we know about medical malpractice claims is that every single one of them does have unique circumstances, but when you have a grouping of them and a collection of medical malpractice cases, then you're able to see some common threads. And one of the advantages that PLICO now has in being part of the MedPro group is that we are able to participate in the CRICO benchmarking reports that come out every year. So there are literally thousands of claims that are going into the CRICO system, which is the Harvard Risk Management System, and our MedPro and PLICO claims are part of that. Clearly, PLICO, thankfully, never had enough medical malpractice claims to do any kind of trending. But now that we can be part of this nationwide service, we're able to do that. And what we know is that almost every single one of you, no matter what your specialty is, sometime at some point is going to use medications. And so it really impacts virtually every healthcare service. And this study is just going to reveal the risk of medication error is universal. So while it doesn't look like a big number, 1 in 9 malpractice cases involve a medication-related problem, you have to remember that the volume of drug orders and prescriptions in the United States is literally in the billions. Nearly 100 million Americans have 4 or more medications that they are on regularly. And so with the pervasiveness of medication in the use of all specialties, then any claim is worth looking at when it's related to medication. And between us getting everything perfectly right and things going really, really wrong, we have a lot of things in the middle that may not trigger a lawsuit, but they certainly can lead to consequences for our patients. What we're going to look at in these 1 in 9 malpractice cases, the interesting piece of this is that nearly 50% of all of the medication malpractice risks involve 3 different classes of drugs. That is analgesics, anticoagulants, and antibiotics. And despite one of the things that we have had in the last about 10 years, the adoption of automated systems, the rate of MPL cases attributed to medication errors has really not declined at all. So where do these happen, or who is responsible for these claims? And as you can see on the left of the screen, that about 22% are in the general medicine area, and about 13% are in nursing, so that is going to be primarily involving the hospital setting and the inpatient setting. And then as you can see, as you go down, the rest of them are pretty evenly split among different specialties. Clearly, it's not a surprise to us that 82% of all pharmacy cases have something to do with a medication error. So they are obviously a vulnerable service. But also about 30% of psychiatry cases and about 20% of general medicine. So you're looking at about 1 in 5 deals with a medication error. And then you're about 17 with cardiology, and then about 15% again with probably a nursing case in a hospital setting. So now we have another poll, and I'm just interested to see which setting it is that you practice in. So we're going to give you a couple of choices. We're going to say either the emergency department, the inpatient setting, ambulatory setting, or both inpatient and ambulatory. Up to 45. Okay, well, it looks like a majority of you are ambulatory based, and either, so almost 100% of you are ambulatory, and then about 27% of that, you also work in the inpatient setting. And so when we look at the care setting for the place that these medication errors occur, we see that about 50% of them happen in the ambulatory setting, about 42% in the inpatient, and 8% in the emergency department. But if you look down at the bottom, it'll show you, and we're going to talk about the 4 different processes in medication administration. You can see that the management piece for ambulatory setting is by far the biggest chunk of the claims. And it is also the biggest in the inpatient setting. And that is really where we're going to spend a lot of time tonight, is talking about the management of medications. But as you can see, this is why, because the majority of the claims are there. So the medication process really does involve 4 steps: ordering, dispensing, administering, and monitoring and managing. And so we've got ordering, which is the point you've made a decision to order or prescribe a medication until that order is received by the pharmacy or the dispensing service. And then dispensing is from the point the order is received by the dispensing service, which could be the nurse at the hospital, until it is administered to the patient. Administering is the actual act of delivering the right medication to the right patient in the right dose via the right route at the right time. The 5 rights, we've talked about those for years. and monitoring and managing. And that's from the point the patient receives the medication, including their refills, until they're no longer taking it. Nearly 90% of the cases can be mapped pretty significantly to one of these steps. And about 11% of the cases have errors in multiple steps. And what we know is what we talked about, 100 million people are taking more than 4 medications. And so you have one medication that's ordered by one provider to one dispenser to the people taking it. That's so many touch points. And so when you have multiple medications with multiple providers, perhaps multiple places they're actually getting the meds, every touch point has a place where a mistake can be made. And so it just makes a complex process for everyone involved. So breakdowns in the medication process, we're going to go through each one of these 4 steps. And we're going to start with ordering. And the breakdowns that we see in the medication process for ordering involve about 39% of the cases. Antibiotics are the top medication type, and general medicine is the top responsible service. Interestingly, it's actually higher in the inpatient and emergency setting together than it is in the ambulatory setting. But the issues that can happen are the clinician can order the wrong medication for the patient's condition. They have ordered a medication that's contraindicated by a patient's known allergy, by other medications, or an underlying comorbidity, or the clinician's order included a wrong dose or route. Now, interestingly enough, the most common problem noted in medication ordering reflect clinical decisions made by the providers, and that is generally due to the provider not adequately gathering or sharing patient information with either the patient or their colleagues, a referring physician such as that. These are very difficult to defend when a clinician makes the wrong decision in ordering a medication. And because this is so difficult to defend, it actually contributes to the finding that the average payment for a claim that has an error in the ordering process is almost 20% more than any other type of medication error. And so it actually affects the magnitude of the amount of money that's being paid for a claim related to that. Now, some of this has been decreased with these sophisticated, like ordering, CPOEs and all of that. And so in some ways, sometimes that actually leads to some overconfidence because there's not really a human backup. And a lot of times people want to say, oh, well, somebody just clicked the wrong box. And sometimes that does happen. But clearly, the computerization has not eliminated any of it. And really, it still shows that it is more about the clinician, the physician, making the right decision for the right medication than it is about clicking the right box. So the patient's exposure to the risk of a medication error, this does not include ER. It varies by service. And again, as you're going to see, the inpatient side is really about, more about ordering, and the ambulatory side, we're going to be seeing later, is more about managing. But general medicine and ambulatory is the highest area of concern here. And the other one we'll be seeing a lot of is cardiology and talking about that. And clearly the ordering pieces in the inpatient are going to be reflected in those things that are happening in the inpatient setting, orthopedics, OB, general surgery, and that type of thing, nursing, obviously. But as we talked about, the inadequate assessment of hospitalized patients prior to medication ordering increases the likelihood of severe injuries or death, and that is the highest contributing factor that we see in ordering, is that inadequate assessment. And as we can see here on the right, 43% of inpatient medication ordering cases involved a patient death. That is a really high number of deaths. And when you add then contribute to that the high severity injuries, you're getting up into the 50 and 60% range. And as you see, you never get to listen to me talk that we're not going to talk about communication. And as you can see, 54% of these patient deaths involved an assessment error, which included failure to read the patient record, inadequate or incomplete history or exam, or failure or delay in ordering a diagnostic test. So you're really talking about talking with the patient, being sure that you're following through with your diagnostic test results and those kinds of things, because those are still the problem areas that we see with medications. So what are some opportunities for improving ordering safety? Well, I've been out of the hospital setting for about 12 years now, and probably about 5 or 6 years before I came out of the hospital setting, we heard the term medication reconciliation for the first time. And I still think that we are trying to figure out what that means and what it looks like and how to do it well. It is certainly a moving target, especially for patients, again, with multiple medications, with multiple providers, and who have chronic illnesses and then also have underlying acute things that might happen to them, putting them in the hospital and trying to figure out what they need to do with their medications when they're discharged. But robust medication reconciliation is very important to be sure that people are not double dipping in different things, and we'll talk a little bit about that and when we get into the management piece, and that they are not taking things that are contraindicated after they've had a different event happen in their medical history. Pharmacy-managed allergy registries are very important. Medication-related decision support tools, those are those pop-up boxes that all of us love so much, but they are important for you to recognize that you might be ordering something that has a contraindication or some sort of reaction, interaction with another medication. And then a standardized assessment of inpatients prior to medication ordering is one of those things that is sort of a checklist that people are really hesitant and don't really love it when we give them the word standardized, but this is just a way that we keep from missing out on something. And I always use the example, if you're flying with a pilot and they just decide today we don't really want to use the checklist, is that the pilot you want to be flying with? And right now, not me at this point. So as you can see on ordering areas, we did talk about antibiotics and as being the number one drug class that this comes to. And then we see anticoagulants and analgesics. Again, those three we're going to talk about a lot today. And the top contributing factors is that a necessary medication was not ordered, a medication inappropriate for the patient's medical condition was ordered, or the most appropriate medication was not ordered. And as you can see, those are all physician decision-making impact and contributing factors. The injury severity, as you can see in this, 33% of these result in death, 19% in high severity injury. So again, over 50% of these claims resulted in either a severe injury or death. Dispensing, we're going to get through pretty quickly because really this is kind of outside your purview unless you actually are dispensing medications from your office. So the pharmacy dispensed the wrong medication, dosage, or composition. The pharmacy incorrectly prepared the medication, or the pharmacy failed to recognize and flag an allergy or an intolerance to a dispensed medication. And as you can see, only about 3% of the cases actually involved a dispensing error. And with this, the top medication type was cardiovascular drugs, and as you can see, now we're getting into that ambulatory area of being where most of these things occur. And of course, pharmacy was the top responsible service. So a couple of the things that we see related to dispensing errors, no matter the fact that we have been talking about look-alike, sound-alike drugs for, again, 20 years, we still have things in the pharmacy that look exactly the same, except perhaps one letter, a couple of letters are different, the coloring is the same, and all of that. And so we are still looking at those human factors that in the process that we can improve on. The other thing is there are black box warnings, and just as physicians will click off of a pop-up when they're doing an assessment of somebody and they know it doesn't have anything to do with it, we are seeing that then people who are preparing the medications for dispensing are also ignoring those black box warnings. And again, those are things that can be tracked very easily in your computer system, and obviously the plaintiff attorney can find that and see that it was clicked off on. Again, about 57% have pharmacy as the primary responsible service. And as you can see, the top medication categories, they're just in a little bit different order: cardiovascular drugs, antibiotics, and anticoagulants. The top contributing factors are 85% are a pharmacy dispensing error, 31% policy and protocol not followed, and 23% the administration of the incorrect or inappropriate dose. Interestingly, the severity on these injuries is I say only 23%. That's still 1 in 4 patients had either a high severity or they died. But I mean, compared to 53 or 54%, that's obviously a different situation. Along with the dispensing and comes administering. And again, wrong patient, wrong time, wrong medication, wrong dose, and wrong route. I have been a nurse too many years, so and we certainly learned this, and it was old hat by the time I was doing it. And so the 5 rights of medication have not changed, despite the fact that we have all of this automation and all of those kinds of things. And what we find in this, and again, about 14% of the cases are related to administration. Analgesics is the top medication type, and we're tied up down there at the bottom with the setting. And nursing is the top responsible service. But what we see is most of the time is that there's a deviation from standard processes. And so something is altered in the way that the nurse or the provider is providing and administering the medications, and it causes them to go the wrong way. That's why standardization is so important. We have things, again, ignoring pop-up boxes, getting into, I'm afraid to date myself, the Pyxis machine, that's what we called it, I'm not sure what it's called now, and putting in the wrong medication, taking it out, not paying attention, drawing it up, and going ahead and putting and administering it to the patient. One of my favorite stories is about all of the new technology is the hospital in town, and again, it's been over 15 years ago, actually put into place the little barcodes on the bands with the medications and the barcode on the band for the patient so that they would be sure that they were getting 2 green lights when they clicked on that. Well, it kind of got sort of it was sort of a hassle because some patients, the band didn't get on there quite right, or their wrist was really thin and they couldn't get it to flatten out. And so the nurses, being nurses who are the experts at workaround, in my day when I was a nurse, we could pretty much get anything done. They decided that they had an idea of how to make this better. And so they actually put the armband on the patient's bed and started using that, clicking on that, which clearly completely defeated the purpose of making sure you were giving the right med to the right patient at the right time. But those are things that happen and that we see in the administering process that lead to these errors. And then there's also miscommunication. Again, not communicating with your coworkers, and about 32% of these administration cases had that type of a contributing factor. Again, we know that near misses are pretty common in medication administration, but serious patient harm really isn't that common. And so sometimes when there's a near miss, most of the time, we don't take advantage to figure out what the process problem was behind that. And so by allowing these systemic faults to be continually just masked because nobody was hurt, we lose the opportunity to find a process issue and fix it. I tell people all the time when they call me and they say, oh my gosh, this happened, but thank goodness nothing happened to the patient. And I will say, this is like a blessing. You should be taking this. You should be doing a root cause analysis. You should figure out why it was easier for the clinician to make a mistake than to not make a mistake, and you should fix that. And so you really want to take advantage of those near misses. But we also see lax patterns and practices, and again, we talked about workarounds, and those can actually lead to egregious errors with much more adverse outcomes. And so really patient safety in this piece of it really depends on kind of a covenant amongst all of the people who are involved in the process to adhere to a standardized set of policies and procedures and not to do workarounds, not to take shortcuts. We do also see disruptions with multitasking or texting, people getting texts while they're in the middle of giving or drawing up a medication or writing an order or heading to write an order or something like that. And so what we also recommend is that you have sort of a no distraction zone when you have people who are drawing up medications, who are entering the orders for medications, and that they are singularly focused on that medication process. So again, the top medication categories: analgesics, antibiotics, cardiovascular drugs, and about 35% were for the wrong dose, about 32% were the incorrect or inappropriate drugs, so that's kind of could be just the order was not entered correctly, and the policy and procedure not followed. And again, so here we're at about 36% high severity or death. So what are some opportunities for improvement in dispensing and administering areas? Well, we want to be sure that you monitor adherence to policies and procedures. You want a structured practice for dispensing cabinets. Question atypical medication orders and deliveries. I always told my nurses at the hospital, if you have to get like a 30 cc syringe out to give a medication, you probably need to check on it. There were some other things that we said, if you need to give more than 3, call the pharmacy for single dose medications, things like that. Just that if it seems odd that you're having to give somebody, 5 pills at once, then maybe you should kind of look at that. The other thing that I always say is if a patient you come into a patient's room and they say, I've never taken that medicine before, you need to listen to them and check on it. Because if in fact they are lucid enough and understand enough to question it, they're probably going to be right. You want to identify and improve the faulty systems like we talked about with the human factors engineering, with the lookalike packaging, the easy overrides, and all of the EHR challenges that go with it. I was actually reviewing years ago an EHR program where you had to click completely out of the patient into a completely different screen and then find the patient again to find their medications. It was so user unfriendly. It was so hyper intensive searching and so many opportunities for landing on the wrong page. It was terrible. So I know there are EHR challenges, and hopefully some of those have been resolved over the years. But communication is very important, and we've talked about communication. I think last year we actually did communication and talked about the importance of provider-to-provider communication. And if there is a provider-to-provider communication error in a claim, you're so much more likely to pay more money. They expect you to talk to each other. They expect you to have their best interests in mind, the patient does. And they expect you all to be sure that you're on the same page. And again, we also have patient-to-provider interaction as well. So now we're going to get into the management piece, and that piece is the part that is most important because about 56% of the cases involve a management issue. And the breakdown in the monitoring and management of patients really account for most of the problems within the claims for medication errors. And when you order something, it implies you're committed to managing the immediate and the long-term effects. In inpatient, a lot of times medication ordering is done sort of in controlled chaos, right? And we're trying to figure out what's going on. It's very short term. But office-based care management issues are really more commonly associated with chronic conditions and long-term use. You regularly have to reconcile what's been prescribed, what's actually being taken, how the patient is responding, and then any maintenance medications really have to be reviewed whenever the patient has a new symptom, if they have a new diagnosis, if they go into the hospital for anything, and have an invasive procedure, if they have any of those things, you really have to look at that. There really needs to be a gatekeeper. The patient needs somebody who can be looking over all of their medications and being sure that they are not having something that interacts with something else, or is actually they're allergic to it, or it's completely not what they need to be doing. So for inadequate monitoring assessment, we have the patient's adherence to his or her medication, their physiological response to new, change, or short-term medications, the patient's physiological response to long-term medications, and then any abrupt or temporary alterations in their medication regimen. So you have to monitor all of those things. And then the other thing is inadequate education to the patient or family about the risks related to these medications. So before we go to the next slide, I'd like us to pull up the next poll. So, do you use written educational materials when managing patients using high-risk medications, or do you not use them? Okay, so I was super excited when you first started, because those of you who got on first, it was like 90% said you use written educational material, so I was kind of excited about that. We're now at about 2/3 do and about 1/3 don't. And so this can lead to what we might believe as being the non-compliant patient. If you're actually using or not using patient education material. So this is sort of a misunderstanding. The patient in the hospital was taught to inject insulin by injecting an orange. They were readmitted to the hospital with dangerously high blood pressure, and we learned that the patient was injecting insulin into the orange and then eating it. So really not a great way for the insulin to affect their blood sugar. But we hear this all the time. I hear all the time from pediatricians who say that a patient's mother put their antibiotic in their ear for their ear infection, or gave them a suppository by mouth. Those things we kind of go, oh, that's kind of, that's kind of comical, but there can actually be things that happen for our patients that are not at all comical. They're not at all funny, because they can lead to disasters and tragedies. There's a case on the East Coast where a mother had her 3-year-old child in for surgery, and unfortunately, the insurance company told them the next morning that they needed to go home because they weren't going to get to pay for any more hospitalization days. And so when the mom heard that, she wasn't very happy, because the baby was still having some issues, and I'm sure she'd been up all night, and she was tired and just was hoping to have some more support. But when she had to be discharged, she was discharged. They sent her to the pharmacy with a prescription for pain medication and an antibiotic. And as you can imagine, she went to the local pharmacy with a screaming kid, and also, she had to wait for 30 or 40 minutes for this prescription to be filled. And so when she got the medication, she went up to the pharmacist, and the pharmacist asked her the required question. The required question is this: do you have any questions about your medications? She's tired. She doesn't care. She's going to just figure it out. All she wants to do is get home. So her answer is no. And technically, the pharmacist was able to check the box, okay, that they asked if there were any questions, and the patient said no. Unfortunately, when the mother got home, she did have questions. She had never given a medication. They had sent her home with a prescription where she needed to use a syringe to draw it up. The baby presented to the ER the next morning, unresponsive, because the mother had given the baby 10 times the dose of the medication, and the baby died. So this is tragic. And it's all because the question was not right. The question that you ask your patient is not, do you have any questions? Do you understand what I'm saying? The question is, have you ever given a medication with a syringe before? Do you know how to draw up this potentially deadly narcotic to give to your child in the correct dosage? Because then probably she wouldn't have said yes or no, or that she doesn't have any questions. So we really recommend, again, when you are starting a new medication with a patient, when you are changing a medication, but specifically on high-risk medications, and the written materials are so important. They're going to save you time, because if you even tell a patient, oh, you have high blood pressure now. I can remember getting that diagnosis, and even though it wasn't, to me, it wasn't that big of a deal, it was devastating to me as I began to think about being on medication for my whole life. So if you're telling somebody something even more disturbing or distressing, remember, they're only going to remember that's all you said, and they don't remember much more from that. And so the written materials are going to be very important to save questions down the road. But when a patient comes to see you and they are finished with their office visit, they are finished with their ER visit, you are getting ready to discharge them home from the hospital, the worst question you can ask is, do you have any questions? Because they're going to say no. They're not going to know enough to ask a question. They don't want you to think they're stupid. You've got your hand on the door, so they know you're ready to go. But we also don't want them to feel like you think they're stupid. So one of the ways that I have seen and we talked about this last year, so I'm bringing it back up, to talk with your patients about what they understand about their condition, is to say, Mrs. Foster, that's my mother. When you get home today, Sherry is going to call you. And she's going to want to know what we talked about today. And she's going to want to know what our plan is. What are you going to tell her? And let then her tell you back in her own words to see what it is that she understood from what you were sharing with her. And was it the right message? It is not her responsibility to be sure you give her the right information. It's your responsibility to be sure you give the right information and that she perceives that information correctly. So, as I said, always a soapbox about talking with your patients. So opportunities for improving monitoring and management safety. We talked about medication-specific patient education. I love that 2/3 of you are doing that. I would encourage you, if you have things that you routinely use in your office, that you can do some sort of an education sheet where you have places at the bottom to individualize it. I would encourage you to do that. Scan it into your EMR. Then when somebody calls, they have a question, whoever takes the call can look at their EMR, can see what the instructions were instead of having to find the person who did the discharge to see, well, what did you tell them about it? So it really is an efficiency improver for you as well. Standardized outreach, phone calls to recently discharged or non-adherent patients, and systemic reconciliation with change of status, care transitions, and discharge. Again, as you look up here, analgesics, anticoagulants, and antibiotics are our top categories. Failure to monitor medication regimen, inadequate education, and miscommunication are the three things that most often contribute to these claims. And as you see there with injury severity, 54%, high severity injury or death. We also know at the top, if you can see this is 49% of all medication cases involve a high severity injury or death. So we know that of all. Then 27% of all medication cases are high severity or death and breakdowns in monitoring or managing. And then we also have 12% also include these three medication categories. So that's why we're going to be looking at those. The other thing is very important, we'll talk about this in anticoagulants. So analgesic, anticoagulant, antibiotic cases, you can see how those are spread across the different services, and just to see that a majority of them, again, are going to fall into that general medicine issue. General medicine scope, it's the biggest group, so of course that's how it's going to happen. And what we will know, we'll talk about in a minute, is that primary care does actually do the most opioid prescriptions. Again, some differing things here, but as you see at the top, the biggest issue is improper selection or management of therapy. Across the board for all three of these is the highest contributing factor, and then the next one is inadequate patient monitoring. And you can see that patient non-adherence is higher in analgesic cases. That's not a surprise. In the other ones, it's not terrible. It's about 1 in 5, and sometimes those, especially the anticoagulant cases, are so complex about what they're supposed to be taking. You can understand that they might not understand. Again, delayed or inadequate documentation, always an issue in cases. Miscommunication, and then the clinical system breakdown is going to be your processes that we see. So real quick, managing errors for antibiotics. We know that about 30% of antibiotics over the last 5 years were deemed to be unnecessary. And so we really encourage you. I know patient satisfaction with antibiotics, it's not as bad as it is with analgesics, but certainly when a mom comes in with a kid who's been crying for 3 days and they think they need an antibiotic, and you say, they really don't need an antibiotic, and they're not happy because they came in to see you for an antibiotic, then I understand how that it can impact it. But as we do know, the antibiotic stewardship is super important, and we need to be sure that we're ordering things that need to be ordered. Maybe that will slow down a little now that they're not actually bringing anybody in. You're just seeing them on the screen and with your telemedicine visits, and they won't be quite as upset that they didn't get their antibiotic. But we'll see. But the antibiotic stewardship is super important, because also if you give somebody an antibiotic, the chances that they're going to finish it because the kid gets better in a couple of days, and they don't want to fight with them to give them the antibiotic, and so you just have that never-ending cycle that we know with that. Anticoagulants, this is the one where there can just be there's so much opportunity for failure on the part of follow-up. So we see that 43% of the issues are in ordering, and about 67% are in management. There's lots of high-level coordination that has to go on. Thankfully, we have gotten some meds now that don't require the testing and follow-up and just the consistency for the patient. But we still have to be sure that we're monitoring those things and that we're looking into things, and they understand the risks of those anticoagulants for other things, like if they have a fall or something like that, that they need to be sure that they're letting people know that they're on these medications, if they're having other invasive procedures, if they're having dental work, whatever they're having, that they know that they need to let them know, let that provider know. Mismanagement can be severe, even fatal. About half of these cases did result because the patient had died. They were triggered by a patient death. And this makes this actually, anticoagulants are the second. That's still, even that, they're still just the second leading factor in increasing the probability of a patient death. So if there is an error in the management of anticoagulations, the patient has a 68% increased chance of having died related to that error. So now what we came to talk about tonight, analgesics, and as I said, the anticoagulants are the second leading factor in predicting a patient death. As you can see here, if there is an error related to analgesia, an analgesic, it increases the odds of a patient death by 163%. And as you can see here, again, it's about 76% of these are in the management of those. And about half of them happen in ambulatory, and then we have about half in the inpatient and emergency. As you can see, Dilaudid is the top. followed by morphine, oxycodone, and fentanyl. And so some opportunities for this are the provider education on postoperative pain management. What else can we do to manage pain after post-op, for post-op pain, and vigilance related to polypharmacy and medication reconciliation. So important to know what your patients are on, who's getting the meds. The PNP has definitely helped this, and people using that is it is a tool, an assessment tool for you, and you should look at that as a benefit in knowing what patients are receiving from other providers. Of course, there are risks beyond malpractice with the DEA and the OB/NDD. Licensure boards, all of your licensure boards, there can be criminal charges, and I do believe that we are seeing some increase in scrutiny by all of the licensure boards, by the DEA, by the OB/NDD. There is pressure and scrutiny related to the prescribing of opioids, and they're making examples. I don't like to say that, but we have definitely seen that for some of our providers that are really feel like they're doing what they're supposed to be doing. We've seen these all over the place, and the two on the right are really just about the opioid settlement that we just finished in Oklahoma last year. But you see some of these about physicians being indicted, murder trial, family losing sons to the opioid epidemic. It's really hit the news, and people are knowing about it. And I expect that we will see a lot more of this. This is certainly one of the ramifications that we believe we will see an increase in this type of activity after as the COVID-19 sort of dies down, and I'm sorry to use that, but sort of fades out a little, and we're seeing other things in the news. We feel like these are some of the things that we're going to be seeing with patients who have not been able to get in to see you to get their regular prescriptions, so they're having to turn to other medications, street drugs, those kinds of things. Certainly, this one was a shock to most people in Oklahoma. I believe that she will be going to trial in October. She's actually charged with 5 murder. She has 5 murder charges against her, and as you can see, for a 4.5 year period, she prescribed more than 3 million doses of controlled dangerous substances. 5 of the people who died had more than 1,800 pills in the same months of their death. So these kinds of things certainly come to the attention of not only your licensure board, but also the Attorney General and the DAs. The major reason for the CDC and all of this national and state legislative involvement is because of the opioid deaths. There were 72,000 overdose deaths in 2017. They're mostly from non-prescribed opioids and lethal combinations, especially with benzodiazepines. We do know that illegal opioids are outpacing prescribed opioids. Some other strategies, CMS is looking perhaps at a hard stop in 2019. We didn't see that. I guess I need to update this slide. We didn't quite see that. But the DEA has reduced manufacturing of opioids in 2017 and again in 18 and then more in 19. So we have heard that patients, it's difficult for them to get them sometimes, and other reasons are that pharmacy chains, insurance payers are having varying policies. Walmart has a policy, Walgreens has a policy. Many states have capped at 90 to 100 MMEs. There are lots of new laws. This is what led the state legislature to look at our law. And then there's some increased investigations of providers and pharmacies. I do believe that the tragic death of Austin Box was one of the things that really brought this to the attention of our lawmakers. It had some very high-profile people in the government who were very interested in that, and his parents got their ear. And then we also had another businessman, very prominent businessman in Oklahoma, Bob Howard, who had a family member who passed away as well. And so those two things really stirred a lot of the action down at the Capitol. There was some surveillance in 2017. We did participate. About 59% of the deaths were due to illicit opioids. 18% combined prescription and illicit, 18% for only prescription. So about 1 in 5 were just for prescription. And about 50% of these also had benzodiazepines, hence the reason that the benzo piece is so important in the legislation. I really like this slide because I think it's interesting because when we talk about prescribed opioids, you want to look, first of all, you want to look at the right-hand side. And as you can see, one doctor prescribes about 81% of the meds. And then you've got the other things here. They got them from a relative. They had more than one doctor, but those are really small. But you look over on the left, and you see that 55%, that is what's happening in that 81%, is what happened to those other meds. They got them free from a friend or relative who had gotten them for one day from one doctor. Maybe they stole them, but this is one of the reasons that they have really wanted to limit those initial opioid prescriptions. They do not want a bunch of leftover opioids in people's medicine cabinets. And so I have a doctor who speaks for me often, and he is a pain management doc, and he says, my biggest fear in life is that the police are going to call me, and they're going to say, we found a kid on the playground at this junior high or at this elementary school, died of an overdose, and there's a prescription bottle in his pocket that has your name on it. That doesn't mean that doctor gave it to him, but this is one of the reasons that they have locked down so much on the number of pills that people are being prescribed, so that they're just not hanging out there for people to find, to use, to share. So when you're managing analgesics, you want to realize that chronic pain is very complex. Opioids alone only work about 25 to 50% on improvement in pain scales. It can be highly beneficial, but, sometimes it's not. And so the sustained pain relief over time is not well established. The improved function is uncertain, and then there are serious risks related to that. So we're really looking to reduce the use of opioid prescriptions in chronic pain. So who does it work better for? The ideal patient has well-defined pathology, they have good insight, they want to improve, they're willing to work hard, they're interested in other modalities. They don't come in and say, hey, all I want is that drug that starts with a D, that's all I want. They're not focused on opioids, but they're on their desire to improve. And they have a good understanding that opioids will provide some relief, but not full relief. The wrong patient that we've been dealing with for a long time has diffuse and poorly localized pain. They don't have any interest in a workup. Look, I've been hurting like this for 20 years, just give me my meds. Like I said, they not only do they focus on opioids, sometimes they focus on a particular opioid. They have poor insight and unrealistic expectations. They're not really motivated to work hard, and then they also experience poor functionality. All right. So in your chat box, we are going to upload a link that is on our website that has all of these resources that I'll be talking with you about the Senate bills. They're all on there. They're all available to you, okay? And we have a poll, just because I'm interested to know that if you have made significant changes in your prescribing patterns since November of 18, or you have not made significant changes since that time. Okay, good. Okay, so it looks like about 95% of you have. I will tell you that we have heard that there are some doctors, and we'll actually have a poll question at the end to see, they just quit prescribing opioids at all, quit taking new patients who were on opioids, and they just decided to be risk averse and not do it at all. The original bill was actually put in place in 2018, and then they had to kind of fix some stuff in 2019 that they realized didn't make a lot of sense. And so an opioid, this applies to any opiate or opioid, which means a Schedule 2, 3, 4, or 5 substance having addiction-forming or addiction-sustaining liability similar to morphine or being capable of conversion into a drug having such addiction-forming or addiction-sustaining liability. One of the things they did try to do in the second iteration in the Senate Bill 848 is they tried to make it just for Schedule 2s, and that did not fly. So tramadol is still on the list, okay? The major points of emphasis, addiction and abuse, dose reduction and cessation, emphasis on the lower MMEs, alternative therapies, and there's strong language for assessing, documenting, and specifying your care of the opioid patient. So here is another poll. Do you prescribe opioids for chronic pain, acute pain, both, or you do not prescribe opioids? Okay, we're good. Okay, so most of you do prescribe for both chronic and acute. I'd be interested just offline to know how many of you did prescribe opioids before the law and now you've decided not to. I'm just kind of interested to know if that was something that made your decision. Chronic opioid therapy it is a consensus agreement that it can be used carefully in selected patients. The guidelines demand constant attention and compliance as with any medical problem, documentation, vigilant monitoring for abuse and diversion, assessment of opioid-related side effects, and understanding of opioid use in chronic pain. Your selection and risk stratification, the history, physical exam, and diagnostic testing, a psychosocial risk assessment, being sure that you understand, the patient understands and has the correct expectations for the therapy. This is underdeveloped for a lot of clinicians. They haven't done that in the past. And so, what is their risk for addiction? What is their risk for diversion and those kinds of things? It does emphasize documentation of the progress of the patient to the treatment objective. So just remember about that. Patients are at risk, anybody with psychosocial issues, obviously a history of addiction, any adverse childhood experiences, and each one of those just markedly increases the risk of a patient being prone to addiction, being prone to abuse, being prone to misuse of the medications. Poor motivation and lack of insight, interestingly, disability, Medicaid, prior criminal activity, unrealistic expectations, probably the biggest one. We don't ever want to tell someone you're going to be pain-free, and a prior overdose obviously is a risk. So as we were talking about, they have really limited, and I'm sure you guys have all seen this, the number of pills that you want to give to a patient, or they want you to give to a patient. So an initial 7-day prescription for acute pain is for an opioid-naive patient, and that means somebody who hasn't had an opioid for a year for this particular type of injury or condition. Acute pain episodes include dental procedures, renal stones, or an ER visit for an unrelated pain complaint. And interestingly, a chronic pain patient can actually have an acute pain episode that falls into this. If they have something that's completely, say they're on a chronic pain medication for a back injury and then they have a knee replacement. So it's really important that those things are coordinated with the two physicians. It shall be for the lowest effective dose of immediate release opioid drug. And one of the things that I had heard before the law, and this actually came in the second piece of the law, is that pharmacists were filling prescriptions for not what you wrote, or they were obviously questioning it. So this statute, actually, the one that went into effect in May of 2019, says that the pharmacist has to fill the prescription as it's written, or they can choose not to, but they can't sort of fill it, okay? And so they have the right not to fill it, but if they do, they have to do it to what you actually ordered. And it has to state it's for acute pain. That's new in the May 19 as well. You must check the PMP and document that or include it in the chart. And one of the things, failure to check the PMP may, after investigation, be grounds for discipline. So that is part of the new 848 bill as well. So you want to take and document a thorough medical history, include experience of the patient with non-opioid medication and non-pharmacological pain management, screen for substance abuse and addiction, conduct and document a physical assessment, and develop a treatment plan focused on what the cause of the pain is for the patient. Any patient under 18 who their parents, you have to do a patient-provider agreement with their parent. If they're emancipated, you can do it with them, and any patient who is pregnant on the first one have to do the patient-provider agreement. This is the example. This is only page 1 of 3, but this is on the website link that we put in the chat box, and you can access that here, and this meets all of the requirements. I will say that the Medical Licensure Board, the OSMA, the OOA, the Osteopathic Board of Examiners, all of them got together and did at least give you guys and gals some resources for this. So I'm happy to say that. Prior to issuing the initial prescription, you need to document risks of addiction and overdose, the risks of combining alcohol, benzos, and other CNS depressants, and why you are having the prescription and what other alternatives may be available. You have to specifically talk about opioids being highly addictive, even when they're taken as they're prescribed, developing physical and psychological dependence, taking more opioids can result in fatal respiratory depression. I think that's interesting that they actually use those words instead of say, can have you stop breathing. And mixing any of these things, sedatives, benzos, or alcohol with opioids can also result in fatal respiratory depression. And so you might want to say it could cause you to stop breathing because they may not understand what that means. And document this discussion. A subsequent one, they did also actually they added an opportunity for those of you who are doing surgery to kind of get in a second one just so you didn't have to see or talk to everybody. And so if the patient meets the status defined for confined to home or it is due to a major surgical procedure, this does not include removal of a wart or mole, okay? A major surgical procedure, or they're confined to home, the practitioner can have a subsequent prescription that they give on the same day, and it has to say acute pain. You have to write on there the earliest date it can be filled, so a do not fill date until date, and then the pharmacist can only fill it up to 5 days after that do not fill date. So you can do that. If they don't meet that criteria, then following the initial 7 days after consultation in person or by telephone or now by telemedicine, right? A subsequent 7-day prescription may be issued if the prescriber determines it's necessary and appropriate. For best practice, the 7-day consultation should be performed by a physician. However, it does not say that. However, I do encourage that it is at least a licensed nurse or more. Will you go back one for me? For this assessment, not your MA, calling them on the phone. That's not enough, okay? And if there was another area we had an issue is, what if someone gets home, they have an allergic reaction to a medication right after they get their initial 7-day, and they can't get another one for 7 days. You can do that. You can give them a new prescription, but you do need to document very thoroughly why you did that. And then the subsequent, you determine it's necessary. You document the rationale. Again, you document in the chart any risk of abuse, that it doesn't present that. This can be, the practitioner can be physician, podiatrist, PA under the supervision of a licensed medical doctor, or an osteopathic physician, or a mid-level practitioner licensed, registered, otherwise permitted. It said that, and it didn't ever really say that a mid-level practitioner was also an advanced practice registered nurse who has prescriptive authority. So they fixed that as well. Prior to issuing a third prescription, you have to do a patient-provider agreement, which is essentially an opioid contract, and it essentially now they become a chronic pain patient, although this third prescription would still say acute, okay? It definitely, let me back it up one, I missed one, okay. Again, all of these things have to be documented before the third prescription. So all the things that you had to do in the first one. So it's really similar to initiating the first prescription. And then the patient-provider agreement, which really discusses most of these things, and it really is essentially an opioid contract. I have a lot of people who are just doing the opioid contract with the first prescription. However, I also had a group that was doing a contract on every patient, which is not appropriate. If you're not going to be giving a patient opioids, then you should not be doing an opioid contract with them. Okay, that they were putting it in their paperwork when you got into the office. That does not meet the intent of this. Okay, and again, you need this patient-provider agreement for under 18 and pregnancy on the first one. Here are all the elements. I'm not going to read these to you. When I send you out the evaluation link tomorrow, I will send you out this presentation. Again, all of these things that are listed here are in the provider agreement that is on the website. And compliance with the consent items constitutes valid informed consent. And this is one thing they added. The practitioner shall be held harmless from civil litigation for failure to treat pain. That's the piece that you would be held harmless from. If the event occurs because of non-adherence by the patient with any provisions of the patient-provider agreement. So if you terminate somebody's opioid contract, and because they have not adhered to the contract, then you have a held harmless civil protection against them saying he or she failed to treat my pain, okay? Chronic opioid therapy, when an opioid drug is continuously prescribed for 3 months or more, the practitioner shall, again, every 3 months, course of treatment, any new information about the etiology, and any progress toward the treatment objectives, and unless contraindicated, try to stop the use of controlled substances, attempt to decrease the dosage, or try other medications. And this is for, there's not a low limit. Like this is 2 tramadol a day to get me out of bed to get me to work because I have rheumatoid arthritis. That counts, okay? Check the PMP. I really, right now, again, you only have to check it every 90 days with this, but I just recommend that you do it every time. They've made it fairly easy. They've let your nurse, your MA, somebody do it on your behalf. Look it over. Also, if you're going to check it, look at it, okay? But it's just another assessment tool. Monitor compliance with the pain management agreement. And if you told them to seek a referral somewhere, document with specificity. I love that. It says that word in the law. The efforts undertaken. Now, this gives you a little bit of an out. So in the first year of the patient-provider agreement, you have to assess the patient every renewal to determine if the patient is experiencing problems, which in Oklahoma is really technically every 30 days, and document the results of that assessment. But after a year of compliance with patient-provider agreement, so once you've been with you've had the accepted patient-provider agreement in place for a year, you can start assessing them every 6 months, okay? And so I really encourage you to get those compliant patient provider agreements intact so that you can make it more efficient for you, for your patient, and for your practice. Some further requirements: you have to do acute or chronic pain. I want you to know it does specifically still say all disciplines, and all the disciplines it says unprofessional conduct is prescribing, dispensing, or administering opioid drugs in excess of the maximum limits authorized section entitled of Oklahoma statutes, and that is a 30-day supply. That is different than the DEA. That is specific to the OB and DD. Your educational requirements: MDs and DOs have to have an hour, PAs an hour, APRNs 2 hours, and podiatrists 2 hours. You must have a policy and procedure if you have a qualifying opioid patient in your practice. So you have to have a PPA in combination with a written policy. And a qualifying opioid therapy patient is a patient requiring opioid treatment for more than 3 months. Does not matter how high or low the dose is. A patient who is prescribed benzos and opioids together for more than one 24-hour period. So they did put a little thing in there for people who just needed like a Valium for an MRI or whatever. And any patient who, if you have a patient prescribed a dose of opioids over 100 MMEs. And again, here is a very nice document that was put out by all of these people at the bottom there: OSMA, Oklahoma State Licensure Board, osteopathic examiners, OHA, OAFP, all of these people with the best practices on it. And basically it just outlines what I've just told you in single space. And again, this is on our website that we sent you. And then we also have a sample policy. So you can individualize this to your practice. Be sure that if in fact you are doing a policy, you're doing the policy, okay? So you want to do that. The OB&DD has some more things they can do related to this. They can do things kind of unsolicited now. So if a patient gets a prescription that is inconsistent with recognized standards of safe practice, if you as a practitioner has prescriptive behavior that seems problematic, and again, failure to check the PMP as required under law may, after investigation, be grounds for licensing board. So that would be part. They aren't going to see if people are checking the PMP except as part of an investigation, and then that could be disciplinary. OB&D is going to be looking at prescribers and dispensers that are in the PMP, data regarding the checking of that, how often are people using it, data from boards related to your continuing ed. I'm not sure how they're going to do the effects on the prescriber workforce. I'll be interested to see if that is just how many of you might decide you're just not going to have an OB&DD license anymore. And then they'll look at the number of patients taking more than 100 MMEs and the data regarding all meds that are prescribed, all opioid meds prescribed in MMEs. It does not apply to patients with active cancer care or active cancer pain, end of life, palliative hospice care, or long-term care facilities. And it does not apply to medications for treatment of substance abuse or opioid dependence. We talked about the civil relief, litigation relief. Now, this active cancer pain is not pain that they're still having post-chemo, and they haven't been on chemo for many years, and they're still having pain related to that. So this is very specific. Here are just some consequences. Again, we talked about that medication cases involve a higher proportion of patient deaths when compared to other malpractice cases. As you can see, cases without medication issues on the right have about 35% risk of high severity injury and death, and cases with medication issues have a 49% chance of those two things. So we talked about almost 50%, okay? Also, medication cases related to all cases have different closed with payment rates. And we've talked about the fact that we have Plico MedPro in Oklahoma. We have a closed without payment rate of about 80%. So any claims that come in, that's without indemnity payment. And so that would mean that our all cases would be, in the closed with payment would be in about the 20% area. And this is nationwide. Medication cases are closed with payment 41% of the time, almost half, whereas all cases, compared to all cases, they're only closed about 32% of the time. They're closed with payment greater than $1 million 4% of the time, 2% for all cases, and their indemnity payment averages about $100,000 more. So you can kind of see this is just shows in all the different types. And we talked about that ordering errors cause the indemnity payment to go up. Dispensing and administering, those two are both the highest close with payment, because with all the different smart tools and everything that people have now, people see that as never events. I mean, you've got the technology to know that you're giving me the right medication. And then managing patients is at the lowest with 35%, but as you can see, are about 56% of the cases overall. And even if you're closed without payment, you know that there's time out of your practice, there are fees related to the discovery, to the legal fees and all of those things, and there's anxiety related to that, there's stress related to that for you as a practitioner. And so it's just better not to have one. Okay. So here are some things to consider with each medication. I'm not going to read all these. Again, they're going to be, the presentation will be in your email tomorrow. But all of the things you need to think about every time you're going to write, you're writing a new prescription for someone. It's not just routine for them. It is routine for you. But really, there's not hardly any medications that are just completely benign and low risk. Depending on the patient and what's going on with them. They either need to they really need to be taking them, or maybe they don't. And so what is it that you can look at sort of outside the box to be sure that you're managing that patient's medications? Medication-related treatment, almost all patients, every healthcare service, and we know that now, looking at this, medication error is universal. They do involve a larger percentage of death. They more frequently close with indemnity payments, and they have higher average payments. And so a commitment to coordination and communication is essential to preventing these med errors. And it is a top patient safety failure in the outpatient setting, the ambulatory setting, making it a prime area for you to improve. Here are some other resources that we have. And would recommend that you look at if you're doing any of these things. And with that, if we have any questions, I think you can unmute yourself and ask me. Is that right? Tracy, do you have any questions from the group? Also, while I have you on here, did everybody, if your name isn't showing up in your little box, can you be sure that you email that to, or chat it to the MD at support Zoom or Zoom support, so that we be sure we have your name? If in fact I look and see the people who are logged in today and you didn't register, I'll also send you the registration link tomorrow and let you know if you already have an account or if you need to set up a new account so that you're sure to get your CME. But in order to get your CME and to be able to report it to the licensure board for the MDs and PAs especially, you need to complete your evaluation. I want to thank you guys. Is there okay, I don't see any questions. Thank you all for your time. Hopefully we'll get to see you in person next year with a really good meal or something. But this was certainly better than a webinar where I didn't get to see any of your faces at all ever. So I appreciate your time. I appreciate Tracy Thomas and all of her help. And if you have any questions, give us a call. Thank you guys.